It's my pleasure to introduce Dr. Alison Smith. Dr. Alison Smith is also McSwain Charitable trustee. Alison Smith was born and raised in Pittsburgh, Pennsylvania. She attended Virginia Polytech Institute and State University in Blacksburg, Virginia, and graduated summa cum laude with dual bachelor degrees in chemistry and biological sciences in 2007. She was presented with Virginia Tech's Woman of the Year Award and further recognized for her leadership role in the Hokies United organization following the mass shooting on campus. In 2010, Dr. Smith founded and served as inaugural executive director for the nonprofit organization Sante Total and remains an active board member. She has participated in trips to Haiti, the Dominican Republic, Mexico, and Kenya. In addition, Dr. Smith served as an educator to train first responders in basic life support and trauma skills with Operation Smile in Southeast Asia. In 2014, Dr. Smith completed the physician science program at Tulane University, receiving both medical and doctorate degrees. Her doctoral thesis on the use of stem cells to treat chronic wounds was under mentorship of Dr. Charles Bellows in the Department of Surgery at Tulane University. Dr. Smith graduated from general surgery residency at Tulane University in 2019 and received recognition as a resident of the year from the University Medical Center. She completed a surgical critical care fellowship at the University of Texas Health Science Center at San Antonio in 2020. Dr. Smith is a trauma and critical care surgeon at the University Medical Center in New Orleans, an assistant professor of clinical surgery at LSU's Health Science Center. She's board certified in general surgery and critical care surgery. And Dr. Smith, again, is our speaker for tonight. And with that, I want to introduce Dr. Smith. And once again, just make a plea for you to please mute your microphones during the presentation. If you have any questions, please use the chat feature. With that, Dr. Smith.
Thank you, Steve. Appreciate the intro. Christy, can you enable me to screen share, please? So I just want to thank you all for this opportunity. I am not, nor have I ever been EMT or paramedic, but I was fortunate enough to meet Dr. Norman McSwain when I moved to New Orleans in 2007, and he convinced me that being a trauma surgeon would be one of the best decisions in my life, and I have not regretted it. So I feel very fortunate that I was able to give you all this presentation tonight. So tonight, really what we're going to be focusing on is talking about how you manage pre-hospital bleeding. And the reason I really wanted to focus on this topic, I have clinical interest and research interest in hemorrhagic shock. And I think it's really important to kind of put it in perspective that you all, as the pre-hospital providers, you're really ground zero for patients that are in hemorrhagic shock. And really what you do before the patient gets to the hospital makes a huge difference in terms of survival, clinical outcomes, and what we're able to do when the patients come to the trauma center. So that's why I chose to focus on this topic tonight. I do have a few disclosures. Really, the only one that's relevant to the talk tonight is that I'm on the advisory board for Primetime, which makes the Reboa catheter that we'll talk about towards the end of the presentation. So let's start with a clinical scenario. You're working a call. It's a Friday night. You get a call that there's a 30-year-old man who sustained multiple gunshot wounds. His initial blood pressure is low, 65/30. His heart rate is 125. He's diaphoretic and pale. When you arrive on scene, he's got pulsatile bright red bleeding from his lower extremity, and you see a pool of blood on the floor. So those of you all in the pre-hospital world, you know when you first hear this call that gunshot wounds obviously can have a significant amount of bleeding, and these patients can bleed out and die quickly even before you get there. But when you arrive and you notice that the patient has obvious signs of shock and has obvious signs of significant bleeding, that's really going to change your management and what you're thinking about that you're going to do in order to stabilize that patient and get them brought to the hospital. So the objectives of this talk is just talk about how you can recognize pre-hospital bleeding, how we can talk about some of the historical perspective on bleeding control interventions, kind of how we got to where we are currently and what's the research that has led us to this point. We'll talk about some different techniques that you can employ to stop pre-hospital bleeding. And then at the end, I have a few case scenarios for us to discuss how you can use some of these adjuncts for bleeding control. So I always like to kind of frame my talks in terms of Dr. McSwain's rules of patient care. I know those of you all who know him or are familiar with him, you probably have seen this before. And the reason I like to incorporate it is that I think for me as a clinician, it really frames how I think on a day-to-day basis. There really is not a day go by or a patient I don't see that, I think about these rules and how to incorporate them. So I think the one that's the most relevant to what we're talking to tonight is do not panic in the face of blood, which, even those of you all who are experienced healthcare providers, it still sometimes can make your heart race when you hear a scenario like the one I read to you in the very beginning. So just an overview on hemorrhagic shock. The definition of hemorrhagic shock is that it's a physiologic state where the metabolic demands of the body are exceeded due to ongoing blood loss, leading to exhaustion and cell death if untreated. And that's kind of a very, clinical, kind of generic term of hemorrhagic shock. But what I think is always important to remember about shock is that when we're discussing it, it's a physiologic state. So there's something occurring in the body that unless you stop it, the patient will eventually progress to death. The death can happen at different times. It depends on the patient's clinical reserve, depends on their comorbid conditions. But it is important to remember that when you have reached the state of shock, there is something going on that unless you fix it, that patient is going to die. So that's why it's so important to recognize a shock state early, and it's important to know how you quickly can intervene. And especially you as the pre-hospital provider, you really have that opportunity in the case of hemorrhagic shock to make a difference and help that patient survive to hospital discharge. So your goal is to stop the bleeding and transfer to definitive care. How do you do that? Well, we're going to talk about that tonight in the lecture. And some of the adjuncts that we're going to be talking about are tourniquets, pelvic binder, pre-hospital blood, TXA, tranexamic acid, hemostatic agents, and then finally the use of a Roboa. So the mortality of hemorrhagic shock, though it has improved in the last several decades, it still remains significantly high. And most of the time that is going to come from patients that have uncontrolled bleeding that for one reason or another, they will progress to that physiologic state that eventually they'll get to the irreversible cell death and they'll be unable to be rescued by interventions. It's thought that about a quarter of pre-hospital deaths are preventable. So if you think about that, for those of you all who are working in the streets, about a quarter of the patients you see in hemorrhagic shock might be able to be saved. There's still a group that is going to be very difficult to manage and treat. And it also might depend on the circumstances, what you have available. But do know that a lot of pre-hospital bleeding can be preventable if recognized and appropriately dealt with. A lot of the research that drives how we practice in the civilian sector has come from military experiences. And I'm going to touch on that in a few minutes when we talk about some of the historical perspective on these adjuncts for bleeding control. The important thing to remember is those of you all who might have been practicing for a few years might remember that really there was this push to give intravenous fluids. And then now we've realized that that is not only detrimental to the patient, but it really doesn't help you to control that patient and really get them back to a normal physiologic state. When you're giving fluids, you're really not giving the patient what they're losing. They're losing blood, so you need to give them blood and you need to stop the bleeding. There really has been kind of an explosion of this idea of pre-hospital blood. And I don't know, if you all practice in a place that has pre-hospital blood. Hopefully you've had an experience like that, but I think it's something that's becoming more common, not only just air medics, but ground medics as well. And just recognizing that, especially if there might be a long transport time, that pre-hospital blood is what we need and not IV fluids. And then tourniquets really has changed the face of how we manage these patients in hemorrhagic shock. And we do know that tourniquets can improve mortality. And we're going to talk about kind of some of that history behind that. But we're also going to talk about where tourniquets can be detrimental, and they are something that you do have to use with an abundance of caution. So I like to show this slide because I think it kind of helps you as a clinician think about how your patient is progressing through the stages of hemorrhagic shock. So this is from the Advanced Trauma Life Support course, which Dr. McSwain was a big part of the creation of that course, and PHTLS, which some of you all I'm sure have taken at different points. And so when you think about a patient that's had a not significant amount of blood loss, class 1 shock, lost only about 15% of their blood volume, which remember, for an adult, that's about 5 to 6 liters of blood is your blood volume. You're really not going to see many changes at all in your physiologic parameters. But as you start to progress through the mild, moderate, and severe stages of shock, that's when you're going to start to see changes in your vital signs that are indicating to you that that physiology of hemorrhagic shock is setting in and that patient is being pushed towards that severe stage of shock. And unfortunately, when you get to the class 4 or the severe shock, when you've lost about 40% of your blood volume, that's when you might be reaching the level of exhaustion. And at some point, no matter what we do, sometimes those patients might be too far into the bad area of physiology that they might not be able to be brought back to a normal state. They are going to enter into coagulopathy. They're going to enter into the lethal triad of trauma with acidosis, being hypothermic, and those patients, unfortunately, might not be able to be corrected despite our best efforts. But I think it's important to recognize because, depending on when you all get called, you might see patients in these various stages of shock, but just know that if you have a patient in these earlier classes of shock, especially if they might be an outlier, such as a geriatric or a pediatric patient, you might see these changes occur very quickly, and you want to make sure that you're not underappreciating what could be going on with your patient. So whenever we talk about trauma and kind of the trauma systems within the United States, I think, those of us that are fortunate to practice within the United States, and I know we have a few people from other countries as well that have developed really good trauma systems. I think it's important to recognize that when we first really started to recognize that trauma was a significant public health issue, and it still remains a very significant public health issue, not to minimize it, but we have over the course of the last 3 to 4 decades really tried to improve our trauma systems so that we are not losing people from preventable deaths. So we used to always talk about the trimodal distribution of trauma deaths, which basically means that if the patient is in a trauma immediately, there might just be some immediate deaths. These are patients that might be decapitated, might have a devastating aortic injury, and those patients, basically, there's not much you as the pre-hospital provider can do. Then we have this group of patients that fall into the late deaths, and those are patients that die once they've been in the hospital, several weeks to months out. And usually those patients are going to be dying from sepsis, from wound complications, from respiratory issues, from kind of other things that are not directly related to their trauma, but are part of the sequelae. Where we would need to make a difference and where we have made significant strides and where you play a significant role is in these first few hours after trauma. And that's the early deaths from trauma. And that's really the significant portion of these patients that could have a preventable cause of hemorrhage that you might be able to make a difference if you intervene quickly. And that's really where we've kind of flattened out this curve. And now we more so talk about the bimodal distribution of trauma deaths within our country in the United States, because we've been able to really kind of flatten out that curve. Can't do much about the immediates. The late deaths are something that we kind of fight the battle in the hospital. But really within those first few hours, we have made significant differences. And a lot of this does come to good pre-hospital care. So what is the role of the pre-hospital provider? It has always been kind of taught this mantra of the golden 1 hour, and that really doesn't come from a lot of necessarily evidence-based medicine. The golden hour was just kind of a concept that came up that, ideally you want to make sure that the patient is delivered to a place that is capable of managing their injuries. So if you are near a small hospital or a hospital that doesn't have the resources that a trauma center does, the idea is to stabilize them and get them sent to a hospital that's going to be able to help them and stop that bleeding. But really, we kind of know more so now with this kind of golden 1 hour is that we really want to focus on what can be preventable and what you can do to actually control bleeding. And it might not necessarily be the golden hour, but obviously the sooner you can do that, the better. And you want to make sure that you try to implement some of these adjuncts to bleeding so then that patient can make it to the place that they need to be to help that. But it might not necessarily, again, fit into that 1 hour just as soon as you can stabilize that patient and get them transported. So the kind of big source of blood loss historically has been extremities, but we've actually really decreased a lot of that death from extremity hemorrhage. And a lot of that came from what we've learned from the battlefield and what patients, have been able to have bleeding control from the use of tourniquets. Where we do struggle is torso hemorrhage, which is harder to recognize, harder to treat, especially in an austere environment, and then also junctional bleeding. So for the next part of this talk, I'm going to talk about those three specific areas, the extremity, the junctional, and the torso bleeding, and how you can recognize them and what might be available for you to help control some of those bleeding. So this slide I took from the Stop the Bleed lecture, those of you all who've taken the course or might be instructors, but I think it's really good. And especially when you might be communicating with lay rescuers, I think it's a really good visual because it helps to kind of help you convey the message that there are extremities where you have options to control bleeding in the form of a tourniquet, pressure, wound packing, junctional bleeding, which you might be able to control by holding pressure and packing the wound. And then you've got your torso hemorrhage, which unfortunately there's not a lot a lay rescuer might be able to do other than recognize it. But as the pre-hospital provider, there are some tools that could be available to you if you're able to recognize torso hemorrhage. So we're going to focus on extremity first. We'll talk about junctional, and then we'll go ahead to torso. So pre-hospital bleeding, how do you recognize a patient with life-threatening bleeding? And that's something that I think can be an easy question in some sense, but also can be a difficult question if you have a patient that might have had torso trauma, because it might be more difficult to diagnose that compared to a patient that has some obvious signs of bleeding. So going back to our first case example that I presented, the patient with kind of a classic gunshot wound to the extremity, pulsatile bleeding, bright red, pool of blood. Those are all kind of good buzzwords or good things that might tip you off to significant blood loss. So not always the case, but for the most part, if you have a patient that has been acutely injured, their blood is going to be bright red. When you start to get more of the dark venous bleeding, that tends to be more oozing, but that rule doesn't always apply if you have a patient that might have had a significant source of oxygen loss. You might have a patient that was, in a fire and might have some carbon dioxide poisoning. So there's kind of different things that might tip you off to a patient having bright red bleeding. But again, it doesn't always follow that rule. And sometimes even having dark venous bleeding, if it's copious enough, if you're not even sure, sometimes you might just have to err on the side and treat it like it's arterial. And then it's something we can always sort out once we have a more controlled environment, because it is difficult to sometimes tease this out in the pre-hospital setting. But in general, if you're seeing pooling of blood on the floor, around the patient, on the bed, that's usually indicative that there's been a significant blood loss. So that really can tip you off to the fact that the patient might have had a significant amount of blood loss before you got to them on scene. So I think that's also an important thing when you're taking in the scene and when you transport the patient to the hospital. That's an important message to convey, because the patient might have lost a lot of blood. Their blood pressure might be on the lower end. They might have kind of equilibrated, but it's important for us to know that they have lost a lot of blood, because we might see vital signs changes later that then could indicate that they need blood or need better bleeding control. And then finally, in terms of kind of how it might be pressurized, for the most part, if it's an artery, it's going to be a higher pressure system. So you're really going to see that blood pumping. Kind of a really bad ominous sign if you hear audible bleeding. That's not always something you might be able to appreciate in the pre-hospital setting, but that's certainly something we see with our trauma patients in the operating room. And that's usually a bad sign if there's that much blood loss that you can actually hear it. But again, even keeping in mind, sometimes venous injuries might appear to be pressurized. You might put a tourniquet on, and then we might come to find out later that it actually was not an arterial bleeding. But again, it can be difficult to ascertain this sometimes in the pre-hospital setting. But in general, these are kind of the buzzwords and things that you're going to look for and listen for when you're taking care of the patient. So again, this is something that I got from the Stop the Bleed course, because we're going to talk about the history of that soon. But I think really it kind of puts it into perspective, right? You all are in this profession because you want to make a difference. You want to save lives. And, it's always, very tragic, but it's really important but to make sure that you take care of the bleeding as soon as you can as well. Sorry, just looking in the chat here, and I see there's a comment about, the significant overuse of tourniquets. Wait for it, it's coming. I've got a little bit of slides on that when we get there. So we'll get there in a second. So, in terms of bleeding control, again, the thing that you always want to make sure is to recognize that you might not have a patient, that you're able to save. But if you do have a patient that, there is an intervention or something you can do to control that, that really is how we want to make a difference with these bleeding control. All right, so we're going to talk about some of these adjuncts that can be used in terms of bleeding control. And so when we're talking about extremity bleeding, using tourniquets, hemostatic agents, pelvic binders, if you have a pelvic fracture, which again is not always the easiest to diagnose from physical exam, but sometimes it can be, but usually an x-ray, and once we can get it in the hospital, can be a little bit more indicative. There's the use of junctional tourniquets, which can be used for bleeding from the vessels in the groin, from the axilla, or even there are some junctional tourniquets that can help from bleeding in the neck. REBOA, which is resuscitative endovascular balloon occlusion of aorta, which right now is mostly an in-hospital technique in the United States. But there are some European countries that have actually taken REBOA out into the field, and they have PreHospital teams placing REBOA. So we'll talk about that in a little bit. Again, the role of pre-hospital blood and how that's really important to try to minimize what we're doing in terms of IV fluid resuscitation, and not only controlling the bleeding, but trying to give the patients back the blood volume that they've lost. And then other things that can help that we'll talk about in the end as well is there are a couple different things you can give. Transexamic acid, which has helped with patients that have fibrinolysis and can help kind of delay the patient from going into coagulopathy associated with trauma, and then calcium, which is really an important and to some extent might be underappreciated way to help elevate patients' blood pressure, especially if they've been given a significant amount of blood. It really can help to make sure that the patient is getting everything that they need to help improve their blood pressure. So we're going to kind of take each of these different adjuncts and talk about them separately. So in terms of extremity hemorrhage, I think we really have to go to Dr. McSwain when we think about extremity hemorrhage, because he really did have a significant role in kind of where we are today in terms of how we're managing extremity hemorrhage and how we've progressed to the point that we have improved mortality associated with extremity hemorrhage. So I remember when I met Dr. McSwain, he had this pair of MASS trousers that I think right now has unfortunately been retired to his medical museum. But Dr. McSwain was always kind of a proponent of MASS trousers. And I think, there are some things that we've now incorporated in terms of the pneumatic capabilities of them to junctional tourniquets that we use today, even though we don't use this specific type anymore. So MASS trousers stands for the military anti-shock trousers. They were actually created in 1903 by a general surgeon who was doing neurosurgery, and he was trying to find a way to keep his patients' blood pressure elevated during surgical procedures. And so the MASS trousers, essentially you place them 1 inch inferior to the costal margin. It covers the abdomen, pelvis, and lower extremities, and you inflate it, and it helps to bring the blood pressure up higher by basically helping to improve the circulation. And so in the 70s, the Committee on Trauma for the American College of Surgeons designated that MASS trousers were essential devices on all ambulance, and they started to be carried pretty frequently. It became the standard of care for hypotensive trauma patients, but kind of over the years, there really wasn't a lot of evidence to support them. They had a high cost, and the really lack of clear indications kind of led MASS trousers to go by the wayside, and as I said, now has been retired to the medical museum. But again, I think kind of the principle of trying to control bleeding and trying to improve blood pressure is something that is important to remember, because really that kind of led the way and kind of paved the way for some of the junctional tourniquets that are kind of starting to be out there in the pre-hospital setting for civilians and have made their way for the military. So I do think that the device, though historical, does have some concepts of bleeding control that really are important, especially in the austere environment when you don't always have the ability to control bleeding from some of these non-compressible sources. So now we go to tourniquets, and I think tourniquets, as I'm sure you all know, and kind of some of the discussion that we've already had in the chat room, really have a controversial role within the history of trauma and medicine. So if you look in the history books, tourniquets were actually first described by the ancient Greeks. And then they were criticized by the Roman surgeon Galen for basically forcing more blood into the wound. He thought that basically it created more bleeding than it helped with bleeding. The windlass, which is basically what helps to secure down the tourniquet and make it tighter, wasn't really created until the 16th century. And that kind of serves as the model for the tourniquets that we use now. They first became popularized during French combat in the 1600s. But then during the Crimean and the American Civil War, they started to fall out of favor again. And a lot of that was because tourniquets were being placed and there wasn't access to definitive surgical care. So tourniquets were being left in place for hours and days, and a lot of extremities were being lost because of the lack of blood flow from the tourniquet and the lack of access to definitive surgical care. This kind of continued throughout World War II and Vietnam. And again, they really, tourniquets were associated with limb loss, with compartment syndrome, with ischemia, because they were being left on for such long periods of time before they could be dealt with. But then fast forwarding to the war in Iraq and Afghanistan, it kind of really changed the tide for tourniquets. And there were a few things that made it different. There was better surgical capabilities on the military side. There was an easier way to get patients dealt with surgically than they had been in previous wars. The technology was better. The access to surgical care was better. And tourniquets weren't looked at as something that was for definitive bleeding control. They were looked at more as an adjunct and something that should be on for a very temporary period of time until that patient can be taken to definitive care to definitively deal with the bleeding. And so that kind of really changed the viewpoint on tourniquets and showed that they weren't as detrimental as people initially thought that they were. So they were eventually integrated into the tactical combat casualty care, which is the military's trauma education form that's used for all of military training. And so in 2005, that's really where tourniquets became a part of that, and also the use of hemostatic agents as well. And then again, it was viewed as not as much as kind of a definitive measure that should be left on for hours, but it's something that could serve as a temporary adjunct and make sure that the tourniquet was not left in place for a significant period of time. Eventually, that led to the incorporation of tourniquets into the pre-hospital trauma life support care, into PHTLS. And again, they started to become more popular within the civilian world as well. And so the picture in the middle, if those of you all recognize it, is from the movie Jurassic Park, which came out in 1993. And there's a homemade tourniquet that one of the characters puts on his own leg during the attack from the dinosaurs. So just important to remember that, you know, it's something that started to kind of make its way back into the mainstream. Fast forwarding to a few years after that, there was an increase in mass shootings in the United States. So I like this map because it kind of shows you it's more of like, you know, like a heat map kind of showing you where some of these events are occurring. So prior to 1966, there only had been 25 recorded mass shootings in the United States. And in this, mass shooting is defined as 4 or more people shot during a single event. But as time progressed on, and specifically within the 2000s and around 2010 on up to 2018, there's been a significant rise in the number of mass shootings that have been occurring in public venues, in public spaces, in schools, and also just urban violence as well, with increased number of people that were shot and injured and killed. And so because of that, that also propelled tourniquets to become more interesting to the public, because unfortunately, there were a lot of similarities between mass shootings and what was occurring in the austere environment in the military. And some of those lessons from Iraq and Afghanistan were able to be translated into the civilian sector. So one of those mass shootings in particular really caused a lot of public outrage, the Sandy Hook shooting, which occurred in 2012. It was committed by a lone gunman. It occurred in Newtown, Connecticut, where he, after killing his mother, went to an elementary school and killed 26 people, including 20 children. And so, you know, obviously, there's always a lot of upset whenever there is a mass shooting, but this really kind of showed from a national perspective that, children were being involved, and this was something that we had to do something about. We couldn't just let this continue on in our country and lose young lives. And so this is about the time when I got to know Dr. McSwain very well. And I remember sitting in his office and he was talking about going to some meeting in Connecticut. And the Hartford Consensus was convened by a subgroup of the American College of Surgeons, including Dr. McSwain, Dr. Jacob, a lot of people that were kind of heavy hitters within the trauma world. And the goal of this meeting was to find a way as surgeons to respond to this increase in mass shootings, in particular following the Sandy Hook shooting, because we couldn't stand by and do nothing. And so Dr. McSwain was really on the forefront of these meetings that then led to some important developments. So the meeting was initially convened in April 2013, and the idea was to create a national policy to enhance survivability from intentional mass casualty and active shooter events, and it consisted of 4 separate meetings where they focused on the use of tourniquets, public education on bleeding control, and how to have active shooter drills and how to manage them. And so a little bit after that meeting, the first meeting, the Boston bombing occurred in April 2013. This was the first modern domestic terrorist attack in the United States. And there were lots of images being circulated in the media of makeshift tourniquets that were placed by bystanders, since a significant amount of the injuries that occurred during that event were to the extremities. No commercial tourniquets were used. About 50% of those patients had an extremity injury, and there were several studies that were published as a result of people who analyzed the injury patterns and some of the autopsy reports, and it really showed a failure of being able to take what we had learned from our military experience and translate that into the civilian world. We didn't have the knowledge, we didn't have the tourniquets, and we had people that died from preventable injuries where we know that there might have been a way to help control that bleeding until the patient got to definitive care. So as a result of all of those events, the Stop the Bleed campaign was first launched in 2015, and the goal for it is to train lay rescuers in hemorrhage control techniques, including applying direct pressure, packing wounds with gauze, and placing tourniquets. And I'm sure those of you all out there have either taken it or you might be instructors of it, but it's a 90-minute course that consisted of didactic presentations followed by a hands-on practice. And so the Stop the Bleed has really become a big public health education campaign. Unfortunately, I'm sure those of you all who come from places that teach it, the COVID-19 epidemic kind of made it very difficult to continue to teach these courses. And we here in New Orleans actually just got our program back up and running. It's a really important program, but a lot of it is making sure that you're repeating the skills and that you provide the equipment that people need, because these are lay rescuers who may never see this event occur, or might see it once in their lifetime, that they're not going to be as familiar with it as somebody from a medical background. And you have to have the equipment available. Otherwise, it's going to be very difficult for somebody to assist in the way that you would want them to. But really, the Stop the Bleed campaign has been a huge program, and hopefully will continue to be a success, though we're still kind of sorting out, all the long-term effects of this campaign. So one big component of the Stop the Bleed campaign is tourniquets. And as we mentioned that, there's been military studies that have demonstrated improved survival, and depending on how the tourniquets are used, there has been associated minimal complications. There were several civilian studies, some of which we actually did in New Orleans, since Dr. McSwain was really an early adopter of translating the tourniquet into the civilian world, that really echoed a lot of those results and showed improved mortality for patients with compressible extremity hemorrhage. Again, this led to increased education and trying to increase the availability of tourniquets and making them accessible to lay rescuers. This figure shows kind of our history of tourniquet use in New Orleans, where 2010 was the first time that EMS placed a tourniquet, which obviously was several years before the Sandy Hook shooting and before the Hartford Consensus, thanks to Dr. McSwain really pushing it with EMS, and then it eventually made its way to firefighters, police, and then it became more widespread once the Stop the Bleed campaign started in New Orleans in 2017. And so other adjuncts that you can use to help with extremity hemorrhage that are part of the Stop the Bleed course, hemostatic agents, wound packing, teaching people how really to pack a deep cavity and to make sure you're not just piling gauze on top, but really packing it deep within the wound to tamponade that bleeding, the importance of holding pressure, not letting go. And then if you do have the availability of gauze impregnated with hemostatic agents such as kaolin, the combat gauze, quick caught, which comes in a variety of different sizes that can be able to fit into the wound that you need it to, really can also help you control the bleeding as well if you don't have a tourniquet or a tourniquet is not appropriate for the wound. So now with kind of this big picture of extremity hemorrhage and all the work that's been done, over the last several decades, there's been widespread educational campaigns, public awareness, and overall, there's been an improvement in mortality from extremity hemorrhage. Some of the data from the military showed that the implementation of extremity tourniquets for deployed forces resulted in 85 decrease in deaths attributable to limb hemorrhage. So this figure here just kind of shows you the amount of kind of how people are dying. And one of the big ways that people were dying on the battlefield was from hemorrhage compared to airway and other issues. And now that with the implementation of tourniquets and bleeding control really has helped to improve that mortality in the military world, but also has been demonstrated within the civilian sector as well. Kind of what we touched on a little bit earlier is kind of, are tourniquets being overused, right? Now it's something that we've had a lot of experience about. We're teaching lay rescuers how to put them on. We're teaching people with no medical training how to do it. But we do know from prior experience historically that tourniquets do have negative effects. And we know that prolonged tourniquet use is associated with nerve palsy, compartment syndrome, limb loss, and an ischemia reperfusion injury, which can cause multi-system organ failure in a patient from all the toxins that can be released. We did a study where we looked back at our tourniquet experience, and we found that about 61% of our patients that had a pre-hospital tourniquet placed ended up not having a major vascular injury. So, again, that's hard sometimes in the pre-hospital world to always have the ability to distinguish a major vascular injury. You might not always be able to tell, if the patient has arterial bleeding versus venous bleeding, and even venous bleeding can be life-threatening. But it is just something to be conscious of now that we've become so pro-tourniquet, to not forget the history with tourniquets. And the military has published some guidelines saying that it's important to make sure that every 2 hours, if the tourniquet's going to be on for a prolonged period of time, you should remove the tourniquet and reassess the bleeding, which again is a hard thing to do if you've got a civilian who's taking care of it and has no medical training. That might be something difficult to do, but it's just to kind of reinforce that tourniquets can't be on forever. And there has been kind of some murmurings, those of you all who keep up with the Ukraine war, and I see, some of the chat was, a lot of our advances and how we perform trauma care comes from conflicts. Well, what's going on in Ukraine right now, there's actually been some literature coming out that, some patients are losing limbs because it's been difficult for patients that have been injured during the Ukraine war to get to definitive care. So they're placing tourniquets, and then the patients are having to go on trains. They're having to have prolonged periods to get back to definitive care to deal with the bleeding, and they are seeing some complications associated with tourniquet loss. And so that's why it's trying to really reinforce that 2-hour rule to make sure that you're not leaving tourniquets on for a prolonged period of time. I know I can tell you personally, like I'm not a military person. I work in a place that has a lot of penetrating trauma. We fortunately have very short transport times, but I did take care of a patient when I was in fellowship in San Antonio that had a tourniquet on for about 16 hours on both of his extremities. It was a crush injury from a car. It came from Mexico, young kid, 10-year-old kid. And he ended up losing one of his legs, and he developed a major ischemia reperfusion injury. And that was the first time I had seen a tourniquet on for that long of a time period. And I saw really the detrimental effects of a tourniquet. So again, I think it's important to be cognizant of when you're placing tourniquets, but also you want to make sure that you are reassessing that bleeding. And again, we'll have to wait and see, over the next few years as we're learning more during the Ukraine war, how that might change some of our practice management with tourniquets. All right, so now we're going to move on to junctional bleeding. And so junctional bleeding is difficult to recognize. It's obviously not as intuitive to see and recognize as you would for extremity bleeding. It's hard to control this bleeding. And as a result, the mortality rate for high-grade junctional injuries is very significant. So even for patients that have a very short pre-hospital time, less than 30 minutes, the mortality rate can still be very significant. And so the military has stated as part of their management practice for patients with suspected junctional bleeding is that you want to try to transport them to definitive care within 30 minutes of the injury. And again, that can be very difficult to accomplish in the austere environment. And that's why the mortality is so much greater and why it's really become more of an issue in some sense in the battlefield than extremity bleeding. And so, again, the mortality has surpassed what we now know from extremity. And so when they looked at some of the U.S. combat fatalities in Iraq and Afghanistan, it was reported that about 18% of potentially survivable pre-hospital injuries were from junctional bleeding. There are some junctional tourniquets out there, and I don't know if any of you all work for a place that uses them. There's a couple times I've seen them in New Orleans, San Antonio, the medics there used them when they needed to. They do take some skill to apply, and they do take some time to apply. So you really do have to have appropriate training and be familiar with the devices. But currently there's about 4 commercially approved devices out there. And I put a couple of examples of what is available out there. But again, it's not something that really is commonplace and is not really as easy to teach as placing a tourniquet. Pelvic binders also play a role in junctional hemorrhage. If you suspect there's a pelvic fracture, there's instability, it really can help to compress the bleeding that you might have associated with junctional hemorrhage until the patient can be transferred to a place with definitive care. And a lot more of our interventions in the hospital have moved to interventional radiology approaches because that bleeding is even difficult for us to get to surgically. And so when you apply a pelvic binder, it really can help with that. A lot of the mistakes with pelvic binders is that people don't apply them correctly. We see pelvic binders come in that are around the abdomen, that are down around the thighs, the level that they should be applied at or at the greater trochanter. So again, it does take some knowledge of how to do it. You have to be familiar with the anatomy, and you also have to have the device available. You can use a sheet if that's all you have available, but the same idea applies that it has to be around the levels of the greater trochanters to really cause that compression in order to control the bleeding. So now we're going to move on to torso hemorrhage, which is probably the most difficult to identify and manage pre-hospital because the patient isn't always going to have outward signs necessarily of bleeding until they get to the progressive point of their hemorrhagic shock, that then you might notice those physiologic changes, and then it can be very difficult to deal with. So the mortality rate for high-grade torso injuries with bleeding was estimated to be about 40% 15 minutes after injury. So, really with torso hemorrhage, you're really on the clock, even more so than some of these other injuries, because again, these patients might not always have any outward signs of severe torso hemorrhage until they get to the later, grade 3, grade 4 stages of shock. And then at that point, they're might hit that point that you're really not able to help them. And so this figure here came out of San Antonio from Dr. Eastridge, one of my mentors. And I think it's an interesting figure to look at because it really shows you the impact of pre-hospital time and how it can be associated with mortality. And so the figure here looks at the torso abbreviated injury scale. So 1 is not so bad, 5 is a pretty significant injury. Mortality is here, and then it shows you kind of your progressive pre-hospital time. So as you get more pre-hospital time with more significant injuries, your mortality rate goes up to about 30%. This was in a civilian database, I believe, that they analyzed. So again, it just shows you that that's something you really have to recognize. It's not always intuitive to see, but it's something that you really do need to get that patient transferred to definitive care as soon as possible. So kind of where the REBOA plays a role in this is that, again, it's not always easy to get that patient to definitive care. And so REBOA stands for resuscitative endovascular balloon occlusion of aorta, and it was designed to address bleeding from torso trauma. And so what it involves, and you can kind of see the picture here, is that you place a flexible catheter into the femoral artery and you advance it up into the aorta. And in the next slide, I'll show you the different zones of the aorta. But basically, you're going to either aim to get it up to zone 1 to get almost complete control of the aorta, or you can put it into zone 3, which is usually more appropriate for pelvic bleeding. So there's been a lot of controversy about REBOAs, and I think a lot of it kind of stems from how it was initially introduced into the hospital setting. I was a resident when we had our first REBOA placed here in New Orleans, and we had a lot of difficulties with learning how to use the device, access site issues, placement issues, because it does require a significant amount of skill to do it. But there has been some literature showing that, when you perform the REBOA placement as compared to a resuscitative thoracotomy, so basically opening up the patient's chest and trying to manually compress the aorta, that there are some patients that have a better mortality rate. It's a less morbid procedure, but again, it does require advanced skill to place, and you can have access site complications that in some patients have led to the loss of their extremities because of complications associated with the REBOA catheter. So this shows a REBOA catheter. Again, you've got your 3 zones of the aorta: zone 1, the ascending aorta down to around your kidneys; zone 2, which includes your kidneys; zone 3, which is your renal arteries on down to your iliacs. And so you get your access site in your common femoral artery. Usually what most places do when they place them, they'll start with an arterial line, then they upsize it to the sheath. The sheath used to be about a 12 French, which caused a lot more access site issues. And now it's been brought down to a 7.5 French sheath, which is smaller, still pretty big, but that's the smallest size that you can actually get the sheath through. And then you advance it all the way up to zone 1 if you want to get total occlusion up here. And then zone 3 is when you're more worried about pelvic hemorrhage. Most of the time, you're not going to do zone 2 because it really doesn't buy you anything right by your kidneys. So if anything, it's better to go up to zone 1 if you're worried about bleeding occurring in different parts of the abdomen. So the REBOA catheter is shown here. This is actually the original version of the REBOA catheter, which is called the ER REBOA. This is what we first placed, and basically the options are total occlusion or not occlusion. And now they've developed a new REBOA called the PreHospital, the REBOA Pro. And so the PreHospital actually can give you partial occlusion of the aorta. It's basically got a stopcock that helps to release the pressure, so you don't have to have total occlusion of the aorta. And the advantage of that is it still allows you to have perfusion below the balloon, so that you're not going to have some of the complications that you might get from intestinal ischemia, renal issues, and issues to your extremities, because you're still getting some blood flow around. You're not totally occluding the aorta, but you're occluding it enough so that you're stopping the bleeding. And so this new generation, the catheter, is not widely available. We were an alpha site for it, and they're doing a DoD study right now to see if the PreHospital is something that should be used in all trauma centers, should be used pre-hospital. There's still a lot of kind of unanswered questions, but it's something that we're in the process of studying, and we are a study site for it. So as I mentioned, the pre-hospital REBOA is something that has been suggested as a way to potentially control bleeding from torso hemorrhage in the field. It's being used in Europe currently for helicopter transports, but these teams usually have physicians that are working with pre-hospital crews and make the decision to place the REBOA pre-hospital. But if you look at some of the literature coming out of particularly England, London, they publish a lot of studies about the use of the pre-hospital REBOA, and they've had some successful outcomes with using the pre-hospital REBOA. Obviously, it's going to require training. It's going to require skill to place this, but this is something the military is particularly interested, because if you have a patient with torso hemorrhage, knowing that the mortality rate is so high, if the REBOA is able to be placed in the battlefield, then that patient is going to have time. And especially with the partial REBOA that we're starting to use more, you're going to be able to keep the REBOA up for longer periods of time and not have some of the detrimental outcomes that we saw with the first generation of the REBOA. So still kind of in the works, hasn't quite made it to the pre-hospital arena in the United United States, but there are some EMS agencies I know that are considering it, and it's something that might have a role in the future, but we're still kind of figuring out the best use of the Roboa within the hospital at this time. So we're going to kind of finish up and talk about pre-hospital blood. And so there's been a lot of literature specifically out of the military looking at pre-hospital blood, and specifically looking at the use of pre-hospital whole blood for severely injured casualties. And so the use of whole blood, there's been a lot of literature that came from Iraq and Afghanistan that showed that the use of whole blood within the austere environment really did help to improve the survival of injured soldiers. There also was the development of the walking blood bank. So you have healthy donors that are able to give blood, and they're immediately able to use the whole blood within patients. We had a talk that Randy Schaefer, who helped set up the walking blood bank in the military. She was here, I think, a few months ago, and she talked about her experience with that. And I think that really was a good indication of how the walking blood bank worked for the military. And it's something that might be able to be translated to the civilian sector if you can develop, a group of healthy donors. San Antonio has a group of healthy donors that are kind of always on call, and whenever there's shortages of blood, they're able to call up their walking blood bank, and it's a really cool thing that they're able to get blood quickly from the community if they need it. In terms of what's been studied in the civilian sector, we really have used initially, the studies that were done was called the PAMPER trial, which was done at multiple level 1 trauma centers throughout the United States. It showed that the administration of thawed plasma was safe, and it resulted in a lower 30-day mortality. But then kind of fast forward, a lot more of the studies that have been done recently have been looking at pre-hospital whole blood transfusions. And the study, the last one listed, was work that we did when I was in San Antonio, and we looked at pre-hospital whole blood, and we found that there was a greater improvement in shock index, and it reduced early mortality within the trauma patient population. Now there's a study going on called the TROOP trial, which we're taking part of with University of Alabama, and that's going to be looking at the difference between giving component therapy and whole blood in the pre-hospital setting, to see if that's something that can help improve mortality and kind of delineate which is the better product to use for our patients. Wanted to include the life flow, and this is something that some of you all might be using. We use it in New Orleans. Dr. Peel, who I don't know if he's on here or not, but he was creator of this, and he shared some of the pictures with me on this slide, so I thank him for that. But it's a really cool thing in that it's a rapid infuser that's hand operated, so it's essentially a gun that you can use to transfuse in blood products quickly. It can be used for crystalloids and colloids. Obviously, in the trauma setting, we use it when we have a patient come in and we want to start transfusing them blood quickly. And so we use that to rapidly deliver the blood products in our trauma patients. And so it's not supposed to be used for massive transfusion. When you get to that point, you really need to have a more automated system like the Belmont or the level 1 transfuser. But this really can help you get the blood products in quickly to a patient that's hemorrhaging, and it's something that can easily be used in the pre-hospital setting as well. I'm going to touch briefly on TXA, which is an antifibrinolytic agent that is used for massive bleeding. There's been a lot of studies done on this, but basically the CRASH-2 trial showed that TXA reduced bleeding in trauma patients. The CRASH-3 trial, which was done in patients with TBIs, showed that it reduced mortality in mild to moderate TBIs. And then there's been some studies that have looked at kind of the use of TXA for patients with severe shock, that they had a better 30-day mortality. And there used to be in some of the earlier studies, CRASH-1, a concern about more thrombotic events, but these most recent trials have shown that TXA can help improve mortality in trauma patients, but not put them at increased risk of having a thrombotic event. And then something that we're doing in New Orleans is something called the ARC bundle, the acute resuscitation bundle. And so it's giving packed red blood cells, TXA, and calcium. And so the protocol for New Orleans EMS, if they have a patient in hemorrhagic shock, systolic blood pressure less than 90, obvious signs of bleeding, that they go ahead and they give this ARC bundle. And this is some of the new data that is being presented by the Tulane group at a trauma meeting coming up soon, that showed that for penetrating trauma patients, they had improved blood pressure, reduced mortality, less intubations when the ARC bundle was used pre-hospital. So that's really cool. It's kind of something that I think is evolving and hopefully will make its way to other EMS companies. So kind of in summary, we've reviewed the different sources of blood loss, what you can do to kind of help control it in the pre-hospital setting, talking about what adjuncts are available to you for extremity bleeding, junctional bleeding, and torso bleeding. And the jury is still out in some of these agents. Some of these we've revisited multiple times in the case of tourniquets. But I think it's important to remember that really, again, you as the pre-hospital provider are ground zero for bleeding, and what you do can make the difference for whether or not the patient survives and what complications they might develop later. So we've got just a couple quick case scenarios, then we'll take questions. So we're talking about the patient from earlier. He's hypotensive, has multiple gunshot wounds in his extremity, pulsatile bleeding from his right lower extremity. So what's bleeding and what adjuncts can you use? So in this case, this patient had extremity bleeding. It was compressible. You can think about giving tourniquet. You can think about using a tourniquet, hemostatic agents, and then pre-hospital blood as well. So scenario 2, you've got a 25-year-old woman stabbed in the left axilla. Her blood pressure is low. She is tachycardic. She has normal breath sounds. She has a hematoma in her axilla. So in this case, you know, what's bleeding and what are you concerned about? So you're worried about junctional bleeding. It may or may not be something that you can compress depending on the location with packing and withholding pressure. But if you do have available to you, you can think about junctional tourniquets, wound packing, and hemostatic agents. 32-year-old man shot in the abdomen. His blood pressure is low. He's tachycardic. There's one ballistic injury shown here in his right lower abdomen. What's bleeding and what adjuncts can you use? So this is most likely a torso bleeding, non-compressible, difficult to diagnose. You always want to think about giving these patients blood. Some of the studies we've shown show that they benefit from TXA and calcium. And again, if you have it available to you, a Reboa might be something to help you control bleeding until you can get that patient transferred to a place that they can definitively manage his surgical issues. So again, just reminding what Dr. McSwain taught us, that if you have a patient that's bleeding, don't panic in the face of blood. This was the best picture I could find of him to show this. I was trying to find one of him covered in blood, but this was the best we could do until Mary can find me the other picture. But with that, I thank you all for your time and attention, and I'm happy to answer any questions that you have.
Dr. Smith, I want to thank you for getting like 120 minutes into 60 minutes for us. That was a great presentation. We do have a couple of questions. One, our friends in Europe, who I must commend you, stayed up till 3 o'clock in the morning with us to do this presentation, are curious about abdominal tourniquets, the new abdominal compression devices that people are coming up with, which is kind of like a variation of the mass suit concept. What do you think of those?
Yeah, I think we don't have a ton of experience with that. I've seen that used a little bit in the pre-hospital settings, kind of a little bit of the mass tourniquet, the mass trousers, plus like a junctional tourniquet. I personally have not seen them. I couldn't find a lot of literature on it, but it is something that potentially could make sense, and it would be less invasive than the Reboa. But again, I think at least in the United States, it's not something we've worked a ton with. But I'd be curious to hear if there's any insights from our European friends.
I almost feel like as an old medic that used to use the mass suit pretty regularly and had some AAAs that we used it on, the data wasn't good, but I think a lot of the old folks had some stories where they had a belly bleed in a bad situation and it gave them some time. I wonder if it was a matter of we didn't know how to do the science, or maybe there's something there. What do you think?
Yeah, I think that's something, especially, some of the literature I did see for AAAs, there was kind of some precedent for it, right? Because that's a patient, even more so than a trauma, that can just bleed out so quickly. So I do think that, it's something just like tourniquets, maybe we'll revisit it in some way, and there'll be a variation of it, whether it be with the abdominal tourniquets or not. But it's something I haven't personally seen a lot of, but I think it's something that definitely makes sense to me conceptually.
Thanks. You also mentioned the tourniquet release stuff. Some of us that are doing citizen and first responder training have split that argument up a little bit, so that if we've got trained first responders or hospital personnel to consider extended time tourniquets for release, but maybe limit that type of information for citizens. Do you think that's probably a good thought process?
Yeah, and I think that's where it's really hard. I teach a lot of stop the bleed, and I think, we definitely want to get the message of tourniquets out there. I think it's easier for us, like, that practice in an urban environment, like in New Orleans, unless it's a big mass casualty, our transport times are pretty small to definitive care. But I do think when you have a setting like the Ukraine war, or kind of really the austere environment, and you might have more civilians and non-trained, medical people managing it, that's something that's going to be hard to get that message across. But I wonder if what we're going to see from the Ukraine war is going to maybe change how we're conveying that message to civilians. So I'm waiting to see kind of what some of the studies from that have shown. But I've kind of heard through the channels that's something that's going to be coming out from what we're currently learning.
And to reinforce, when we're talking about long-term or long-time tourniquets that we're concerned about, we're talking tens of hours, not 2 or 3 hours or 6 hours.
Mm-hmm. Yeah, and some of the data we put together, the multi-center study we did, we had about almost 1,300 tourniquets, and we had some that were longer periods of time, up to 6 hours, and those patients did okay. I think at least the ones I've seen, I've only seen 1 or 2 that have been really the outliers of the, tens of hours. That's where you really do get into trouble. But 2 hours is kind of the line in the sand that we follow from the military right now, but we might be able to push that a little bit.
And we had some questions on the wire about TXI. I started a new one, TXA. Some of the more recent studies too are talking about if TXA is maybe not, at least in a civilian pre-hospital situation, if the data is not there as far as influencing outcomes, but did you see that there's a bit of a change in what we're seeing as far as its effectiveness for pre-hospital?
Yeah, so at least the studies we've done here, and Dr. Duchesne has really been the one that's driven the studies here with New Orleans EMS. With the bundle, they've actually seen some really good outcomes for trauma patients, specifically penetrating trauma. I think if you follow the crash trials, it does show good outcomes. When you have severe TBI, that's when you might run into some trouble. So I do think that it's started to find a home, but there definitely is still some debate out there about, the role of it and potential side effects as well. But, we do use it, and, we have seen good outcomes in our patients.
In any event, the downside is pretty minimal.
Yeah, I mean, really at least the thrombotic event has not played out like we saw in earlier studies. So I personally believe that the downsides are pretty low. It's, something that we do give, and we usually give 2 grams up front. We don't do the 1 gram and then a subsequent 2nd gram within 3 hours. We give 2 grams up front, which is a little different than some places.
I haven't seen more questions. And again, I want to thank you, Dr. Smith, for going over. I know you're on call tonight, so Dr. Smith is actually doing trauma call tonight. So the break where she probably should be having a sandwich, she spent it with us doing this talk. So I want to thank